I would like to acknowledge the traditional owners of the land on which we meet, even if we're doing this virtually. I would like to pay my respects to the elders past, present, and emerging. Welcome, Dr. Ankishete, all the way from Nigeria. How are you?
I'm just saying thank you very much, Agnes, and thank you, everyone. It's like birthing a child after months of pregnancy is a reality. The journey was long, arduous, but I'm so proud of the team, an eclectic group, a very versatile, diverse, brilliant, wonderful job done getting this together. But I'm glad we're starting. Well done.
Thank you so much. Hi, Aliu, my co-host for the night. How's Gambia this morning?
Thank you, Agnes. Thank you for welcoming me. Gambia is here. It's very cool and it's raining. Thank you all for being here. I'm so glad to be part of this. It's really an honor. First of all, my name is Ali Ubidawi Sambu. I'm the president of the Gambia Sickle Cell Association Banjul chapter. I'm a proud sickle cell warrior and also an advocate. I thank you all and I welcome our guest, Dr. Annette.
Hello, good morning, everybody from Brooklyn, New York. Adult living with sickle cell disease, an advocate and a consultant to most of the CVOs here, the community-based organizations. And I'm just glad to be here, and I look forward to us doing this series of informational topics for our international sickle cell community.
Thank you so much. Thank you, Ginger. Hi, Esther. How's Ireland this morning?
Hi, good morning, everyone, or good afternoon. It's actually midday here in Ireland today and a really very wet day. I suppose we're all looking forward to this 10-part series, amplifying sickle cell voices across the globe, and it's been exciting being a part of this team, and well done, Agnes, for bringing us all together. Thank you.
Thank you. Thank you. Natasha, good morning or afternoon in Zambia?
Good afternoon, everybody. My name is Natasha. I'm from Lusaka, Zambia. I am an adult living with sickle cell and an advocate. I'm so excited to join you guys in this amazing series. Excited to dive into the topics for today.
All right, thank you. Well, we are running late and sorry for a bit of hiccups, but I'll quickly go into our program. So as I've said, I'm doing this on behalf of Australian Sickle Cell Advocacy, and I'll just quickly tell you a little bit about our organization before we go into the main topic. So I will just share my screen to tell you a little bit about us and why we're doing this. So to begin with, my name is Agnes. I founded this organization with my husband and my friend Natalie, and we brought other people on board to actually be from one state in Australia. We started off in Victoria, now we're in all states of Australia, and we are a patient advocacy. We started this initiative initially as a social media initiative in 2014, and we got registered formally in 2018. Our main goal is to support people affected by sickle cell disease in all states across Australia. Currently, we have over 100 signed up members and over, I think, 270 now newsletter recipients and over 8,000, between 8,000 and 9,000 followers across all social media platforms. Our governance structure, we are governed by a board. Right now, we have Dr. Margaret Evans-Kalia, who's the one heading our board, and I'll just quickly share my screen to show you people who are in our organization. They usually work behind closed doors. So we are managed by Dr. Margaret Evans-Kalia, who's our interim chairperson at the moment. She's a scientist. And myself, Preston, my husband, who's working right now. He can't be here. Natalie, we are part of the board as well. We've got Sarah Treginza, she's a scientist. She's a board member. We've got Mr. Bright Changanya. He's from public health background. He's also a board member. Dr. Shao Voon, she's a scientist board member. Dr. Anthea Greenwell, who's a scientific advisor stroke volunteer board member, and Dr. Kongolo Kalumba, board member, scientific advisor. Dr. Anthea Greenwell and Dr. Kongolo Kalumba are hematologists. We also have the executive team. We've got Cavasso, Tayo, Peter, Mayase, Christine, and Messi and Lou, who are part of the executive team. So that's us in Victoria. I think as we go along for the 10 sessions, we are going to introduce you to other people who are actually part of this organization as well. So that's what I wanted to do, for us to tell you a little bit about ourselves. But today it's all about everybody on this panel. And I'm so excited to introduce to you my co-host today. Aliu is the president of Gambia Sickle Cell Foundation, as you said. So Aliu, welcome again. I'll give you the floor again to quickly introduce yourself before you can introduce Dr. Annette Ankisheti. Thanks,
Okay,
Aliu.
thank you. Thank you, Agnes. Thank you for that brief introduction of the Australia Sickle Cell Advocacy. I thank you. I said it's a pleasure again to be here. Like I said before, my name is Aliu B.W. Sambo. I am the president of the Gambia Sickle Cell Association Banjul chapter, and also a sickle cell warrior and also an advocate. We have been in existence for 10 years, and we are the only organization in the Gambia that oversees all sickle cell patients. So thank you very much. And from this point, I would like to introduce our subtopic. Today, we're going to talk about basics about sickle cell. First of all, we have the introduction to sickle cell, the need for empathy and not sympathy, fighting discrimination and stigmatization, breaking the silence and breaking the sickle, and misconception about STD. So from this point, I would like to give the floor to Dr. Annette to please give us an overview of sickle cell. Dr. Annette?
Okay, here I am. Thank you, Aliu.
Okay.
Thank you very much. I noticed, Agnes, that I was captioned a hematologist. Let me say, first and foremost, I'm a medical doctor, but I specialize in public health. I specialize in public health. I've worked most of my years in the non-communicable disease sector, and specifically under sickle cell. As you know, I worked as a director for non-communicable diseases, and of course on HIV and AIDS in the Ministry of Health in Nigeria for many years, and then also in New York at the United Nations headquarters, and also of course in the WHO headquarters in Geneva. So I've had a lot of background in the area of sickle cell. Right now, I'm the National Director and CEO of Sickle Cell Foundation Nigeria, that has established the National Sickle Cell Center, the first center of its kind in the whole of Africa. It's a very comprehensive center focused on sickle cell and sickle cell alone, taking care of all aspects of sickle cell, from prevention to treatment and care and support, and now even cure, because we're setting up a bone marrow transplantation center unit in our center. So that's it as far as and I have sickle cell traits, even though that has nothing to do with why I've worked in this area. It was mostly career progression. But of course, like I shared with you, Agnes, my mother was born in a family of many children who died from sickle cell. But at the time, they said they were killed by witchcraft. But you see, when she told us the stories and we could see the signs, and when she described the signs and symptoms, it was clear that they died from sickle cell. But that was many years ago. And then things have really improved over time. If I can have those slides I shared with you, the new ones, Agnes, I'll just run through. There are pictures. So because the picture they say tells is like 1,000 words or even more.
So what I'll do, I'll quickly just ask the other panelists to introduce themselves briefly, and then we'll go through. So at this point, I'll ask Esther to quickly introduce herself before we bring in Natasha and Ginger. Thank you, Esther. And may I just ask everybody who's not on the panel, please put your videos off. Sorry, thank you.
Sorry, I think I was on mute while I was talking. Hello, everyone. My name is Esther Purple Onolememen. I am originally come from Nigeria, currently a naturalized Irish citizen. I'm a mother of 4 with 2 children living with sickle cell, and the oldest living with sickle cell being 21. God help me. And her immediate younger sister is 19. So Charlie, I'm a specialist psychiatric and biggest hospital and community care for people with mental health difficulties. And on the other hand, I am a community person when it comes to awareness raising for sickle cell, and the founding president of Pan-European Sickle Cell Alliance, and also the founder of Sickle Cell Awareness Initiative, Island, Nigeria, and a lot of other sickle cell advocacy groups, you know, here and there across the globe I'm involved in. So that's just a little bit about me. Thank you.
Thank you, Esther. Hello.
Yes. Okay,
So
thank you, Esther.
Yeah.
Thank you.
At this point, I'm going to ask Ginger to introduce yourself briefly, please. Thank you. You're mute, Ginger.
Okay, there you go. Good morning, everyone. How are you? My name is Ginger Davis. I am here in Brooklyn, New York, doing this call today. I am an adult living with sickle cell disease, an advocate, and also a consultant to community-based organizations here in New York State that serve the sickle cell population. And I am involved with a lot of things. I'm a former director of the Sickle Cell Thalassemia Patients Network. Now I work with them as a consultant. I am a member of the coordinating.
Ginger, could you just put your volume closer, please? Your microphone, sorry.
Actually, can you hear me better now?
Yes, yes, yes.
Okay, sorry, I just needed to turn the volume up a little bit. Yes, I am a coordinating member of Synergy, which is a program through the National Institute of Health called ECHO. So we work on that, and it's based around telemed and increasing awareness and ending disparities in healthcare for sickle cell disease. And, you know, it's just a lot of work, a lot of things going on in terms of bringing awareness to sickle cell disease, not only in New York State, but across the country, and informing the population about all of the amazing research that's happening right now, the new medications that are getting approved specifically for sickle cell disease. And we are in a very exciting time here right now.
Thank you. Thank you so much for that, Ginger. Natasha, would you please introduce yourself briefly before we start the main program? Thank you.
Hello, everybody. My name is Natasha Kashito. I am an adult living with sickle cell disease, and I'm an advocate. I'm so excited to be part of this amazing 10+2 series. The thing that brought me to being an advocate is basically growing up in an environment where I wasn't allowed to be who I am for fear of being judged. And so I thought educating people would be something that would bring change. And so here I am today.
All right. Thank you so much, everyone. Again, our hearts go to Greg, who's in hospital right now. He couldn't join us this evening. So, Greg, if you're watching, please get well soon. We need you back as soon as possible. So I'll just give you an introduction because why we are having this series for those people that are not part of the planning committee. And for those people that are not on the panel, please turn your microphones off and your videos. Mr. Victor Ojedo, please turn your microphone and your video off. Thank you. Okay, so for those people that are not part of the planning committee, earlier this year, we decided, Australian Sickle Cell Advocacy, we decided to start connecting with the world using Facebook, because we've been doing this since 2014, and we thought we might as well start because of the COVID, as everybody is affected around the world. So we started our informal organization on 26 April 2014, and here we are today with all these people on the panel and everybody joining us. And that's why we're doing this. So we are simply using this platform after we received a lot of good feedback from the people that came on the talks that we, for advertising purposes and just to have, you know, people relate to what we are doing. We decided to call these talks Sickle Cell Talks with me, Agnes. And that's why we are doing this. So our main goal for this initiative is just to raise awareness and bring effective action in place where sickle cell is prevalent, especially Africa and other Asian countries. So one way we thought we could do this was by holding these discussions to amplify what we called amplifying our sickle cell voices. Again, just giving it that name so that people can actually relate to what we are trying to do. For us, is just raise our voices so that we can bring action. Hopefully after this, we'll come up and see what sort of action do we want out of this. So, I just want to say something quickly before we go into the main sessions. For those people who are wondering, I know some of this, Dr. Ankishet haven't even told you, people are wondering that we are doing this because we want to form an international organization. So hear it from me. We started this with Natalie and Preston and other people in this group doing this initiative. We are not forming an international organization. We have seen the need to organize these sessions to simply raise awareness and give a voice to anyone affected by sickle cell disease, especially in Africa, where this condition is very prevalent. I'm so excited to start this series, and I would like to thank everyone who has been willingly being able to participate in this. And I can't just wait for this to run through and have actions after this and where we go from here. But one thing we are not doing, we are not forming an international organization. So thank you so much. I'll now hand over to my co-host, Aliu, who's going to give us an overview of the sessions today before we go into detail for Dr. Ankishete to give a presentation. Thank you, Aliu.
Hello, Angie.
Yes. I think you may have started already. Just give us an overview, then we give, just go by the run sheet.
Are you hearing me?
Yes, we are.
You can carry on because I'm getting you clearly.
Okay, so, well, thank you. Before we, Aliu talked about that we have different topics for every session for this 12-part series. And today's sessions, we've gone to the basics. It's sickle cell basics. We have 5 subtopics in this topic today. We have introduction to sickle cell disease, the need, and these sessions, we are going to see that these topics came from the group of us who are, most of us in this group are people living with sickle cell disease. And we've got caregivers like myself, and we have a clinician, Dr. Ankisheti, and we've got Dr. Dexter. So this was a group discussion, and this is what we came up with. So the first session, introduction to sickle cell disease, the need for empathy and not sympathy, fighting discrimination and stigmatization, breaking the silence and breaking the sickle cell. And we are going to talk about the misconceptions about sickle cell disease. So at this point, without further ado, I will give Dr. Ankisheti to do a presentation so that she gives us an overview of what sickle cell disease is. Then we go into the different topics and we'll get questions at the end. So Dr. Ankisheti, I'll run your slides for you. Again, I apologize. For those guys from session 2 next week, you're going to have a webinar series, not a meeting. So here are your sessions, Dr. Ankisheti. You can take it up.
Okay, good. Thank you very much. I hope I'm audible.
Yes, you can go ahead.
So the purpose of these few slides is just to help us set the stage. We're talking sickle cell. Let's just remind ourselves what sickle cell is. And there's always new knowledge. So you don't be surprised if you glean a few new things here and there. Okay, so we'll just talk very quickly. Let me get the next slide, please. Very quickly about the story of sickle cell. The what, the where, the how, the when. What is it, who discovered it, when, and so forth. I'll take the next one quickly. What is it? Sickle cell disorder is a genetic disorder, and interestingly, is the most common genetic disorder in the world, which is why you'd expect it to have, by now, we wouldn't be talking of doing advocacy. By now, all over the world, it should be on everyone's lips, but that isn't the case. But what we have come to see is that if you want to push your agenda, you do it yourself. So that's part of why these series are so important. It's a genetic disorder, the most common in the world. And what is the problem? It's specifically a problem in the red blood cell. And in the red blood cell, where is it? In a substance called hemoglobin. That hemoglobin is where the problem lies. And in those who have sickle cell, it's a defective or unusual hemoglobin that is not very efficient in carrying oxygen around the body and helping. What it does, it changes the shape of the cell. We'll come to that. Next slide, please. It's important for us to know that there are different types of sickle cell disorder. You notice I'm using the term disorder rather than disease. This is also part of a way for us to move away from the area of this thing of stigma. We don't want to call it a disease. You're not always ill. When you're ill, yes, you may say you have a disease, but at the moment we know we want to shift the discourse or the narrative to disorder. And I believe over time we're going to hear more and more of disorder rather than disease. So the most common is the hemoglobin SS, which we find here in Africa and in India. We also have the hemoglobin S plus C. We have it in West Africa, in the Mediterranean, and the Middle East. And we have this hemoglobin sickle beta thalassemia. Now, let's remember, many times we hear that sickle cell is a disease of the black man. That is not the case. Let's just remember that it's a global illness. But if you notice this map they're looking at now on the screen, it shows us that sickle cell superimposed on the malaria map is one and the same. So you find sickle cell anywhere you have malaria in the world, and that is across the tropics, from the Americas to West and Central Africa and across to East Africa, to the Asia and sub-Asian subcontinent, and a little bit to the Far East. So you do have malaria across the world. It is global. And the earlier we begin to make it a global issue, the better for advocacy. Next slide, please. And of course, we know it's inherited, being a genetic. So this is one scenario. There's so many scenarios. This is a common scenario we talk about, that when there are carriers, like myself, who am hemoglobin, have both A and S together. If you have a child with someone else who is a carrier, you have a 1 out of 4 chance in every pregnancy that the child you're having will be hemoglobin SS. And then 1 in 4 also of being an AA, that is having a normal hemoglobin. And then 50% chance of being like you, that is a carrier. I want to run through the slides because there are many things to talk about today, except there are questions to answer. Next slide, please. When was it discovered? It was discovered, see, it's in quotes. I put that in quotes because it was not really discovered. But what we have in medical literature is that it was discovered in 1910. But where? In America. Let's look at the next slide. It tells us it was discovered in the USA. All right, in Illinois, in Chicago. Next slide. And who discovered it? It's a gentleman who lived almost 100 years, Dr. James Herrick. He's American. He described it and said it looked that what he found in the under the microscope was that the red cells of persons with a sickle cell, the red blood cells, are shaped like a sickle. And that's why we got the name sickle cell. Okay, next slide. You see what I'm talking about, right? Why I say discovered in quotes is that we have known of sickle cell in Africa for thousands of years, 5,000 years to be precise, under various names, different parts of Africa. In Nigeria, for instance, they had the name Abiku, if you're Yoruba speaking, or Banje, if you're from the East. So it's been here with us. It's just that we did not document it. That's the power of documentation, which is why today we look at sickle cell and we say it was discovered in America by Dr. James Herrick, because he documented it. In history, medical literature, you will see his name against it. This is a sickle. I don't like saying sickle because I didn't see a sickle in my life until I got to medical school as an illustration. So I like to say the red cells are shaped like a banana or like a crescent. Let's look at the next slide. Exactly. This on the left is a normal hemoglobin A red blood cell. It's spherical, rounded, but you see the sickled red cell is shaped like what I call a banana, or crescent shaped, or sickle shaped, which is where it got its name. And that is where the problem lies. That shape of this red blood cell does not allow it to live long, whereas the normal red blood cell will live up to 120 days. The sickled red blood cells die off from the body within 10 to 20 days. So you won't be surprised when they complain of anemia or shortage of blood, for a long. These are blood cells within blood vessels. The basis of this disorder is the misshapen red blood cells, how they clog the blood vessels and block them so that blood and oxygen do not get to end organs or tissues, which is what you see here. And for that reason, there are many signs and symptoms that we can describe. Next slide, please. If you look at this slide, the first symptoms and signs that a mother would complain about would be what we call hand and foot syndrome, swollen and painful hands and feet of the baby. And this you begin to see around the age of 6 months, 7 months, 8 or 9, when the fetal, the kind of hemoglobin you have in your mother's womb known as fetus or fetal hemoglobin begins to wane, and your own genetic makeup begins to show up. So if the baby was actually a SS by nature in the genes, it begins to show up around the age of 7 and 8 or 9 months. And that's when the mother comes to the hospital crying to you that, doctor, this child does not sleep. This child is always crying. And that's because of the painful hands and feet. If the child is fair skinned, you can actually, in quotes, see the pain. And you feel so sorry. All right, so those are the first symptoms and signs we get. Next slide, please. And the hallmark of sickle cell disorder is pain. Pain, pain, pain. I can't overemphasize this. If you interview persons who have had children, they will tell you or share with you that the pain of sickle cell is worse than labor pain. Or sometimes you ask them on a scale of 1 to 10, where is your pain? And they tell you, doctor, 20. And that, in other words, is through the roof. As a doctor, you know that what brings patients most to the hospital is pain. 80% of complaints of patients when they come to hospital is pain. And that is what our persons with sickle cell tend to suffer. Another common complaint is, or sign, which you see as a doctor, is pallor. Shortage of blood is seen in the paleness or pallor of the skin, which is better seen in the palm of the hands. So rather than being nice and pink, you see the palm of the hand being somewhat whitish. And if you test the patient's blood, the blood cells are low. Another sign is the jaundice, the yellowness of the eyes, which can be sometimes very scary. And and persons who have sickle cell who exhibit jaundice, many times we know they're not well treated, they're not well managed, they're not well controlled, because we know from experience that those who are well managed do not end up with severe jaundice like this. And that's because that breakdown of red blood cells, rapid breakdown of red blood cells, your liver cannot cope with it. So the end product is this yellow substance known as bilirubin that colors the eyes and the skin. Yes, what we have here now is what we call frontal busting of the skull. And the reason is this: when the body is not getting enough blood cells, there's a loop back, a kind of mechanism that tells the body there's a problem. And so the body begins to produce more blood cells. And where does that happen? In the long bones of the arms and legs, and also in the bones of the skull. And so they begin to grow. So that's what we call a sickle cell habitus. In some patients, you see them with very long, lean arms and legs and bossing of the skull, sometimes also of the jaw. And that's the body telling itself that it needs to produce more cells. And that's what you see. And I must emphasize that happens when management is not adequate. Next slide. A common finding on examination is swollen abdomens, and that's where you see that from an distended liver and a distended spleen. The liver is here on the right side of the screen, and the spleen is on the other side. The spleen is very enormous. What happens is the spleen is part of our immune system, and it tends to mop up red blood cells, and there's a crisis sometimes. And in some patients who have sickle cell, we've had to remove their spleen entirely. Okay, and in children, you see them with distended abdomens. It's not uncommon. Next slide, please. I put up this slide because it's a very rapidly fatal complication of sickle cell. I'm describing many signs and symptoms and complications of sickle cell here. It's called acute set syndrome. And we tell our mothers that if you have a child who has sickle cell and the child has a fever at night, please do not treat that child like any other child and just administer paracetamol and wait till morning. That child must be rushed to the hospital. It's a medical emergency because it can be rapidly fatal and the child could die within a couple of hours. The black spaces you see here are the only spaces containing air in this child's lungs, whereas the lungs should have air right down to the diaphragm. You see the pockets of air, and that's very inadequate. And the treatment here would be exchange blood transfusion, and in no time the child improves. What happens is that those red blood cells that are misshapen, sickled red blood cells, have clogged the blood vessels that get to the alveoli, the air sacs of the lungs, so that air doesn't get into the blood system, into the bloodstream. Next slide. This is a very devastating and debilitating complication of sickle cell, stroke, which tends to occur in children. In fact, whenever you see a child with stroke, invariably that child has sickle cell. about 9 to 10% of children with sickle cell from the ages of 2 to 16 will have stroke. So since we know that, we try to prevent it. Prevention, this is one place where prevention is actually better and cheaper than cure. In fact, it's very much emphasized, best prevented. When a child comes down with a stroke, I tell you, the dynamics of the family changes forever. So we can't overemphasize the need for preventing stroke. In our unit, in our center, we have a stroke prevention unit where we do what we call transcranial Doppler scan to determine those children between the ages of 2 and 16 who are at high risk for stroke, and put them aside and give them preventive treatment in form of hydroxyurea or chronic transfusion so they don't come down with a stroke. Next slide, please. Chronic leg ulcers, leg sores that just fail to heal year after year after year. I've seen some going on for 10 years, and these are very stigmatizing. I have a patient who is very well today, thanks be to God. In fact, married with one child. She almost took her life at the age of 19 because she was stigmatized in her community. She was given a name in which translated to English means the one with the sore, and she found herself responding to this name rather than to her own name, Fumilayo. She responded to Elegbu Lese. But today I'm happy that she's been treated in our center with a special solution called Asmesol, and she's right as rain. But this is a very devastating, debilitating, and stigmatizing complication of sickle cell leg ulcers. Next slide, please. Another one which is very debilitating is what we call avascular necrosis, or degeneration of the hip joint. We also have it in the shoulder joint as well, but in the hip joint, because of poor supply to the head of the joint, there's an erosion or degeneration or chopping off, eating off of the top of the round part of the head of the femur, the thigh bone, where it fits into the acetabulum, that is the hip bone. And so there's severe pain. Many of them are confined to wheelchairs, and the final treatment for this is surgery in the form of hip replacement. Many patients are receiving that in our center. Next slide, please. So very quickly to round up, one slide to talk about management and control, and in public health we'll talk about levels of prevention. Primordial, primary, secondary, and tertiary levels of prevention, some of which are treatment. Can I have that slide back, please? That slide back. Just want to talk about the This is the primordial. There's nothing we can do about that now because we have the S gene already in our population. Primary prevention, we can do a lot in terms of preventing the risk factors that lead to disease by doing what? Genetic counseling. There's also pre-implantation genetic diagnosis. There's a lot you can do at that level to prevent that gene from getting to the next generation. Secondary prevention actually speaks of early diagnosis and prompt treatment. We have prenatal diagnosis so that you can determine the genotype of your unborn child in early pregnancy. There's newborn screening, genotype testing at the point of care, and so on. Prompt treatment, infection prophylaxis. This is what kills the children before the age of 5. In Nigeria, for instance, we have 150,000 babies that are born every year with sickle cell disease. And they die, many of them, about 100,000 die before the age of 5, mostly from infection. But when they're treated with immunizations and antibiotics before the age of 5, they hit that milestone and they do well thereafter. And then there are other treatments in terms of blood transfusion, extant blood transfusion, bone marrow transplant, hydroxyurea, and all the do's and don'ts that they have to keep themselves healthy at home. And of course, then when you now have complications, you now have to rehabilitate. What if someone has a stroke? There's need for rehabilitation, there's need for surgery, and so on. So we look at it, management and control as levels of prevention. The next slide shows us a child who we looked after, a friend of the foundation, who now is a benefactor of the foundation. As a young child, he was stunted. This is him before bone marrow transplantation. And the next slide shows us the same young man, a year and a half after the bone marrow transplantation, tall and lanky and doing very well. Today he's a graduate and looking after all the patients with sickle cell, giving back to society. And as I shared, I think I shared this with you. Next slide is that management of sickle cell. Next slide, please. Management of sickle cell is not a one-man show. It's multidisciplinary approach. Everyone from public health physicians to hematologists to pediatricians to internists, and then ONG specialists, because these are the young ladies, get married, have children, and we have to look at, because that everyone aspires to, like everybody else, to have children of their own. And so it's a multi-sectoral approach, it's a multidisciplinary approach, and multi-sectoral collaboration, all hands on deck. Next slide, please. I think that's the final slide. Thank you very much for your attention. Good. So that was just what to give us an overview. Thank you very much for listening. Thank you. But I can't hear Agnes. Agnes, your microphone. You are muted, Agnes.
Yeah. I just realized that.
Yes.
Yeah. Well, thank you so much for that overview of sickle cell disorder. I was just saying I need to change my language and always remember that it's a disorder. It's not a disease, only when you are in the hospital. And I don't have Aliu, my co-host, at the moment. I don't know what has happened. But anyway, so we say that we will now go into some of the subtopics that we spoke about. So this brings us to, I wanted us to set the scene. And before we get questions, we need to understand what empathy, sympathy, discrimination, stigmatization, misconceptions, and breaking the sickle cell is all about. So all I did, I just quickly went to Google and saw these definitions and simple definitions for us to sort of know what we are talking about. So I'm sharing the screen now. So again, these are some of the terms that we found are very common, and those are some of the things that we wanted to correct in the sickle cell community. So a medical definition of empathy, they are saying an individual's objective and insightful awareness of the feelings and behavior of another person. It should be distinguished from sympathy, which is usually non-objective or non-critical. It includes caring, which is the demonstration of an awareness and of a concern for good of others. And then sympathy versus empathy, the difference in meaning is usually explained with some variations of the following. Sympathy is when you share the feelings of another. Empathy is when you understand the feelings of another but do not necessarily share them. And then we are going to talk about discrimination in health and social care. Discrimination may relate to a conscious decision to treat a person or group differently and to deny them access to treatment or care to which they have a right to. Stigmatization, the definition I found was that the assignment of a negative perceptions to an individual because of perceived difference from the population at large. It may occur on the basis of physical appearance, including race or sex, or mental or physical illness, or of various other qualities. And then the difference between discrimination and stigmatization is that stigmatization is a negative stereotype, and discrimination can be described as an unfair treatment that results from stigma. So one is a stereotype, and that discrimination, it can occur as a stereotype from stigmatization. Misconception, this is defined as a conclusion that's wrong because it's based on a faulty thinking of facts that are wrong. And for breaking the silence is purely to breach a norm against communication or against communicating a specific type of information. So those are the terms that we want to talk about today. And I hope Aliu is back now, who's my co-host. I can't see him. So based on that, now that we know the meaning of these terms, we'll go on the panel to just tell us how you want people to treat us. And I'm putting us in one bracket as caregivers, but mostly people who are living with this condition. Empathy and not sympathy. Oh, hi, Aliu. I lost you for a bit, so you can take over after this. So empathy and not sympathy, and why did we bring up these issues? So I'll start with Esther. Esther, after the overview of sickle cell disease, why did we come up with wanting to be treated with empathy and not people having sympathy for people living with the condition? I know you and I are caregivers, but we are looking at this from a person living with the condition, and we're going to speak to Ginger and Natasha specifically, and Leo, who are going to give a perspective from a person living with the condition. But you as a caregiver, why did we pick people being empathetic than being, have sympathy for us? Thank you, Esther.
Yeah. Thank you there, Agnes, and thanks very much, Annette, for that very detailed, background to sickle cell basics. I suppose a lot of things Annette would have covered in her presentation would have transpired in my life. My daughter now lives with, lifelong stroke as a result of complication. She's suffered, series of complications. For instance, she suffered hyperhemolytic syndrome. She suffered acute chest, syndrome. She's experienced, her lungs collapsing and a lot of other things. She was on life support for a very long time. She's had splenectomy. She's had ulcer. She's been through, name it. So you can imagine, as a parent myself, while my daughter was going through that phase and was in life support, her blood levels were like dropping. The highest, her hemoglobin levels could be was 2 at a time. And like, she was on what we call the washing machine here, for instance. I'm sure Annette knows what I mean. And it was so much going on at that time. At that time, as a carer, even as a carer, I didn't think sympathy was what I needed. What I needed was empathy. People to understand where I'm coming from. Unfortunately, sickle cell is, something that is only a growing concern in Ireland. We would have been the first generation of families living with sickle cell in Ireland. My daughter would have been one of the first cases in Ireland. And so you can imagine, for almost 20 years or so, the barriers I would have had to go through to make people understand what sickle cell is, how it does affect me, and the need for me to have empathy instead of pity. Even people from the African community, lacked that knowledge, because Annette had covered areas where misconceptions, you say, I don't want to jump. These are all the things that make people begin to pity for you or begin to have sympathy, like, more like, some people wouldn't voice it, but they are praying for your child not to die because the child has sickle cell. You understand? But a parent like me, no matter how sick she was at that point in time, I wasn't seeing her death. I recall when my child was very young and she said to me, how long will I live, Mom, because of the frequent ongoing in and out of hospital. How did I respond to her? Again, as a carer, it is how we empower our children and bring them up. Sympathy or empathy begins at home. Yes. You as a mother or a father with a child with sickle cell would have to learn the language you use. You have to learn how to include your children, because mine has, a permanent disability now. So that is very devastating and hugely stigmatizing. But I tell you that my daughter, yes, she repeated 2 years. She's behind her age mates, but she's very proud. She's in college now, first year, trying to become a social worker herself. So it's all about how it begins from home. The first time she asked me that question, and what was my response to her? I said, listen, anybody dies at any time. You don't have to have sickle cell to die. Somebody could die of a simple headache. Somebody could die of anything. So as each day comes and goes, we have to be thankful be happy that, you know, we can wake up to the beautiful morning that the Lord has made. I'm a Christian. Sorry if I'm offending anybody else here. You understand? And my faith works for me. You understand? So whatever you believe in, you know, hang on to that. You need to learn to include the children. You need to mind your language. You need to learn to not exclude your children from social activities, physical activities, extended family. I know it's a huge family secret. So when we're talking about sympathy or empathy, it begins from home. How within the family sector, like Annette already identified, when things like, you know, very stigmatizing crisis happens to a child, it causes the family dynamics to shake. And I know that for sure. If you have children, I've done research, you know, a groundbreaking research in Ireland, globally, in fact, you know, and you would find that in that study, a lot of family break down from having children with sickle cell. So when we talk about sympathy or empathy, what we want, we begin to portray how we want to be treated or how we want our children to be treated by the way we treat our children, by the way we include them, by the way we have this mentality of, in Nigeria particularly, I'm sure Annette can, you know, attest to this, people with disability are put behind closed doors. People with devastating, stigmatizing, you know, conditions are named, are called after those conditions. We have to sensitize ourselves. We have to sensitize our community. Nobody will do it for us if we don't do it. Otherwise, sympathy will continue to follow us. I stand proudly. Some people say stamp out sickle cell. I do not campaign for stamp out sickle cell. Exclude me from that movement. Why? Because that's stigma on its own. Because I can't stamp out my 2 children with sickle cell. Do we throw them on exile, or where do we send them to? I cannot stamp out my children. We have to come to terms that, listen, sickle cell is going nowhere. We will continue to educate the community, the healthcare professionals, the policymakers, everybody, but we cannot delete sickle cell from the face of this world. We can only advocate for precision medicine, for precision medication, and every other thing to come into place to enable us manage our children to live a lifestyle. Thank you.
Yes, thank you. Thank you. Thank you so much, Esther. Thank you so much. I will quickly go into Ginger. Ginger, what are your views on having empathy versus feeling pity or sympathy for people living with sickle cell and caregivers as well? Ginger, please. Thank you.
Well, I talk to people all the time about, you know, having empathy and understanding, particularly from medical professionals. You know, Dr. Inez mentioned earlier the pain scale. I actually just said that to someone yesterday, that a lot of the evaluation tools that are used in healthcare don't measure and don't match the experiences of a person living with sickle cell disease. The pain scale is 1 to 10. And
sorry, Ginger. Dr. Ankishet, is it the volume again?
Yes, please. She's not audible. Maybe move
please
closer to your microphone.
Yes, please put your microphone closer.
No, what I will do is put my headset in because that's
okay.
Yeah,
please.
I think that way is better.
Get every word you're saying.
Yes, yes. And for those people that are joining, please just put your cameras off. I apologize. It was my mistake. I should have done this as a webinar. We are here as a meeting. So once you are admitted, please put your camera off and your microphones. You are going to be put on camera and the microphones on if you've got a question. Thank you so much. Ginger, go ahead. Did we lose her?
I'm putting my headset in. Hold on, I just have to plug it into the computer. Okay.
Okay, she's putting on her headphone.
Okay, yeah. Well, I think whilst we are doing that, I think I'll go to
can you hear
Natasha.
me better? No, I'm
yes.
here. Can you hear me now?
Yes, much better now. Much better now.
Thank you.
Good. All right. So, as I was just was saying that, talking about
Now we can't
sympathy,
see you. We can't see you.
yes, that's because I was changing I'm
We
Okay.
plugging.
can see you
Okay.
now.
Just talking to people, and just yesterday I mentioned to someone, a nurse actually, about in the medical profession, some of the evaluation tools that they use in healthcare that is standard for most people don't actually work for sickle cell disease. So if we just talk like Dr. Ness said earlier about the pain scale 1 to 10 is not appropriate for sickle cell disease. We're coming at it 10. We usually coming in at 15, and in acute crisis 20. When we get to 10, we're kind of like, okay, I can almost function. When we're at 7, we're ready to go home. Other people at 7, they can't function. So just the understanding, I think it's hard for people who are healthy, who've never experienced the level and the frequency of pain that happens in sickle cell disease, to understand what that is really like. The people, medical professionals in particular, that had empathy with those who had conditions like fibromyalgia, arthritis, where they were living and experienced pain, understood. Most of the time, it's sympathy, and it's really hard for healthy people to have empathy about what we experience, because they're not going to experience that level of pain. First, with my pregnancies, right? I slept through my labor. And my second child was 8.5 pounds. you know, and I slept through that. Where I'm hearing women in other rooms screaming when my water broke. I'm like, yeah, he's about to come out. And the nurse is telling me, shh, other people. I says, no, I don't understand that screaming. I says, because this labor pain is nothing
Nothing
compared to a sickle
compared to
cell
sickle cell
crisis.
pain.
Nothing. I slept through it. I woke up when I felt, when my son kicked and the nurse touched my belly and the water broke. I was ecstatic. I'm like, all right, it's time for you to get out. And a lot of other experiences. Now, I've been fortunate. I had my share of crisis as a child, but by 11, it started to taper off. And between 11 and 15, I had no crisis and actually forgot that I had sickle cell disease. And again, between the ages of 21, I think maybe a few crises, but I lived 37 years crisis free. And I did it because at 10 years old, I decided I didn't want to be in pain for the rest of my life, and that I was not going to let this disease take me out of here. My mother had to listen to doctors up until the time I was 10, telling her I wasn't going to live another year, until I said, listen, you're not my maker. My number is not in your book. Stop saying that to my mother, because she's making me crazy. And I was like, I'm not going to do this. And I started to learn what was causing triggers. We have to we have to understand our disease better. Too many people are living with this disease and not understanding and knowing what it is. So we can't articulate, we can't advocate for ourselves, nor defend ourselves properly with this disease. The shame that we are made to feel is not coming just from our family. It's actually coming from the people who are supposed to be taking care of us. A lot of the stigmas that are associated with sickle cell disease came out of healthcare, not out of the community, not out of society in general. I meet doctors all the time who have never seen somebody with sickle cell, and they don't know right away that I have it. And one of the first things that come out of their mind, oh yeah, isn't everybody with sickle cell disease a drug addict? Lack of education, from medical training. Until now, you only had about a quarter page about sickle cell in a textbook. Now there's volumes of work, but you had people coming into healthcare that were going to be responsible for children and adults with this disease who don't know what it is. And to this day still have a disconnect about the physiological manifestation of the cell sickling. And when I said earlier that this is an exciting time, you have companies like Novartis that give presentations about the tale of two cells. It's not just the red blood cell sickling and becoming viscous and sticking. The white blood cell is in that. The platelets is in that. And then you have this whole cascading effect. And then just with Novartis, they did a 3D simulation, which I keep hounding them. Everybody needs to see this. We need to show this more, for people, for families to see physically what's happening in our veins and in our bodies, for medical professionals to see what's happening, for people in education from elementary through college to understand this is what we're living with. So in order to get empathy, we're not going to get people to have empathy because they won't feel that kind of pain. Maybe they can have it because now they have the visual image in their head to understand, oh my gosh, this person is suffering. And so there's a lot that has to be done. This meeting right here, us being on Zoom and being on Facebook Live and constantly talking about everything to do with sickle cell disease is going to raise awareness. It is going to create a higher level of education. And hopefully now we'll start to see some change in how people perceive this disease, how even we perceive this disease, and how we start to get better care across the board.
Yeah, well said. Thank you so much. Thank you so much, Ginger. I will go to Natasha just because we don't want to be here 3 hours. Natasha, please come in. Empathy versus sympathy. What are your thoughts on that? Thanks, Natasha.
I will be very brief. Well, basically, sympathy is very disconnected, and I think sympathy is more like, if I, for instance, when I'm talking to somebody else who has sickle cell and they come to me with a problem, I don't make it about me. I make sure that I acknowledge the person and pay attention to them. And that is me showing empathy towards this person, rather than me changing the whole scenario and making it about myself and, oh, when this happened to me, this is what I did, or this is how I do it. I rather try to understand where they are and what they're feeling, what they're going through, and I try to put myself in their shoes. Being dismissive of someone's feelings and just what we're trying to fight. So many people will come to me and tell me, no, Natasha, you should do this, drink that, but it doesn't work out for everybody. So instead of being dismissive of someone's feelings and feeling pity for them and saying you cannot participate in ABCD because you have sickle cell disease, is just disorder, is because they feel sympathy for you. And it's just so disconnective. And that's all I have to say about it.
Thank you. Thank you so much, Natasha. I'll bring in Aliu before we give the floor to you. Are mute, Dr. Annette. So Aliu, then we'll go to Dr. Ankisheti before we finish this subtopic. Aliu, what are your thoughts on sympathy versus empathy?
Thank you, Tanya. I totally agree with what everybody said, because looking at what empathy and empathy, I think what I always tell people is disability does not mean ability. Like genius, they can never feel empathy. They will never feel empathy because they don't know how it feels. They don't know, they have experienced the pain. That is why it would be difficult for them to understand. All they do is just titles. But I think everything has to start from us. That if we don't take a bold step, if we act as normal people, people will always sympathize with me. What I do, I'm Joban. I'm just like, yeah. I said to myself, because when I was young, I see how people sympathize me, because when they look at me, oh, dead in the next 2 years, that makes me feel bad, feel demoralized. I feel hopeless in life. So I have to take a challenge. I have to take another turn. I have to say, you know what? Whether they like it or not, I'm gonna leave. I'm gonna leave because, like you said, they creators, so they can determine we're gonna die every day without having sickle cell. So are they better than? What's the difference? You know, dying and living with sickle, these are different things. If your time is up, you must go. You have sickle cell, because we've seen babies that die that are less than two months or just 2 days. So I have to take both steps. Tell myself that, you know what, I have to leave. I don't want people to sympathize with me. Anything that they ask me not to do, I will challenge myself. You know, we have to let people understand this is just an illness that we have. We have people that are more serious and they're still living, and they're not that much like they look at sickle cell patients, but it's because of the lack of education, the lack of awareness that why people feel sympathy. According to what people used to tell me when I was here, they would tell me, okay, if they say sickle cell patient, if you're 7 years, you will die. You know, this is why people pity us, because they look at it, oh my God, he will probably in the next year. You see, with this type of mindset, people will always sympathize because they feel like, okay, he's not gonna stay long. You know, like Ginger said, like the problem is from caregivers. Some of them don't even know what sickle cell is. You know, you go to the hospital, you tell a doctor that I'm a sickle cell patient. They start looking at you with surprise, as if, you know, they don't know anything about it. That's the problem. They need to do more research on this. I call on government and lawmakers to impose this kind of laws, to ask all health workers to read about sickle cell, because this is something that few people of society have, but a lot of people are having it. I am asking caregivers to read more about sickle cell, because definitely when you sympathize me too much, you demoralize me. I feel I can't do anything in my life. This is the, so definitely I totally what everybody said, and I would definitely like to thank you, Agnes, for taking over, because the connection is kind of bad here. But thank you for on me, and then having my back. Yours.
All right. Thank you so much, Aliu. I'll bring in Dr. Ankishet before we close this subtopic, just being mindful of time. What are your thoughts on sympathy versus empathy?
Thank you, Agnes. But I just want to ask, let me ask Ginger. Ginger, are you listening? Can you give me an example of a scenario? What, in that scenario, what would be sympathy? What would be empathy? I ask because I have a feeling that this issue of sympathy and empathy is culture related, and we have to walk a fine balance. I know that here in Nigeria, we're very sympathetic people. Mm-hmm. And I have a relative a very close relation who has lupus. It's a chronic illness, right. And there are many things that she's been told she cannot do. Mm-hmm. You know, and as an older Nigerian woman, I go to her and I'm ready to help her do everything. Bring this, you can't do this, you can't do that, you can't do that, you know. But I see there's a pushback, and people around her think otherwise. So let me ask Ginger, you live in New York. Mm-hmm. Give me an example of in a scenario where you'd say this is sympathy and this is empathy. Ginger?
Wow. I think that, you know, there are people that I've encountered in my life who've been sympathetic about me not being well. One time I walked into the ER, I was coming from a formal dinner, so I was dressed up. I had a fur coat on. I'm walking in, and I walked in, and the looks that I got, you know, was, is this the patient? and somebody actually said it, and I said, yes, I am. And there was one nurse that was there who knew me, and she says, wow, if you're in here, you're really not feeling good. So I think she was empathetic.
Okay.
You know, people will come in and say, you're not feeling well, how are you doing today? I'm sorry you're feeling bad. That can be sympathetic. But somebody to relate, you know, I think because we live with disability, we can empathize with somebody who has lupus. We can empathize with porphyria. We can empathize with rheumatoid arthritis. We understand that pain. We understand not being able to do all of the things that you want to do. And the moment you're getting ready to do something you've been looking forward to, you're sick. You know, it really is about the understanding. Whether the person can feel the pain or not, if they can understand suffering, they can understand that this is not what you want. You don't want to be in the hospital. You know, this is not a vacation spot. It's the hospital. You miss your bed. You miss your own food. You know, you're constantly being woken up for vitals. It's not a respite. We don't want to be there. So somebody who can understand that and try to make your hospitalization as comfortable as possible, or staff in the ED when you're going in for a treatment to prevent going into an acute crisis, and they, they do everything quickly and they take care and they, speak to you well. That's
Okay.
empathy. I consider that empathy, because they understand I'm here for a reason. I'm supposed to be a healer, and I know this person is suffering. There can be empathy there, but it's about understanding, not really knowing what our pain is like or the damage that it causes.
Okay. I would just like to leave out here for something, food for thought, something for us to think about, depending on where you are in the world. Let's start thinking about it and educating those who are either healthcare givers, or relatives, family, and so on. Let's remember that there's a fine balance between sympathy and empathy, and it is culture related. It is culture related, depending on where you sit. From where I sit in my community, my cultural community, traditionally we're very sympathetic people. So you are going to hear things like sorry, oh, perhaps you're feeling what I don't feel sorry for me. Sorry, oh, sorry. Let me lift your hand. Let me lift your foot. Let me do this for you. You can't do a thing for yourself. But you don't want to feel that way as a person who has sickle cell. You can do a lot of things. So I'm not sure what your response should be. I see patients saying, some patients are vocal about it. Some persons are vocal about it and say to me, and sometimes overreactive. They overreact. I see that in a lot of persons with sickle cell. Let me be. I can do this myself. I can do this myself. And many times they go overboard. Remember, so we have to rein them in a little. It's culture. So let's just remember, it's culture related. We can educate persons who are sympathetic and not empathetic. They mean no harm. And let's also, as persons who are living with a disorder, not feel too bad about it. I think I'll leave it there.
Yeah. Well, thank you so much. I won't say much. For me, just quickly as a caregiver as well, I think over a lifetime, for people on this panel, some of them who don't know, my child lived with sickle cell disorder for 10 years. She had a bone marrow transplant about 18 months ago. And I still will continue this work because it comes from my heart to advocate for people who are still living with this condition, caregivers, and people living with the condition. So during our lifetime as well, caring for a child with sickle cell disease, we, endured all that. And for me, I think I would rather somebody has empathy for me than sympathy. And as Annette has said, it's a cultural related thing. People will be surprised that, I'll be at work, I'll be laughing, I'll be doing this. Sometimes I'll go at work and my daughter will be in the hospital and they'll be like, what are you doing here? Because they don't understand. For me, I do not like anybody feeling sorry for me. Help me do something. Help me post an article on social media or something. I would rather that than feeling sorry for me, because I feel we all go through something, and other people go through different challenges, and sickle cell disorder is just one of them. So this came up very strongly in the group when we were planning this. People are saying, and we have 90% of the people in that group are people living with the condition. I would say about 90. They are saying, don't feel sorry for us. Be empathetic. Try to put yourselves in our shoes, what we are going through, and how can you help us walk this journey. But don't cry and, I'm in the hospital. Like right now, I'm talking to Greg right now. You can do this. I'm not feeling sorry for you because I know you're going to beat this. It's just one of those tiny crises and you are going to beat it. And this is what the people in the group are saying. As people living with the condition, be in our shoes, but don't feel sorry for us, because every one of us is carrying something. Whether you are healthy or not, we are all carrying something. And what we need is that just understand what we're going through, but do not feel sorry for us. So I think that's how I understood this topic. But we are so running out of time and we just have to go quickly. The next thing that came up was, Aliu, do you want to take this up, the next one?
Aliu there?
Yes, Angie, thank you much. I would love to take one. It says, what kind of discrimination or stigma does sickle patients face in society? That is Americas, Europe, Asia, Africa. Yeah. Do you get me all? Do you all me?
Yes, we heard you. Who's going?
Yeah. I think all the people on the panel have that question. Yeah, so just say it again so that the people who are joining us can understand the question. You can go ahead, Aliu. You are mute.
Are you all hearing me now?
Yes, go ahead.
Okay, thank you. Thank you, Agnes. Thank you very much. The next one says, what kind of discrimination or stigma does sickle patients face in the society they find themselves in? That is the Americas, Europe, Africa, or Asia. So, yeah, can you please the floor?
Did we get that? So I think the question was,
Hello,
what kinds
Ginger?
of discrimination? And I think this question, maybe we'll go to the next one, Aliu, because I think that question, Dr. Ankishetia, that's Ginger. Ginger, you're mute.
Yeah, I mentioned that before. That I'm sorry,
Yeah.
I turn my mic off every time I stop speaking. In terms of discrimination, our experience here in the United States is two things: we're fakers and drug seekers. So we're pegged as being, drug addicted, and there is absolutely no evidence to that. I mean, the people I've only in my entire life ever met two people who actually were doing illegal drugs and were addicted to it, but that's because they were getting shoddy treatment. They were getting shoddy treatment in the hospital, and they were being stigmatized in the hospital. And these two people actually were twins, and so they turned to what they could get in the street to manage their pain. I don't know what happened to them after that, but they totally fell out of the cracks, and we don't know how to address that properly. And so the people who advocate, we became adept at understanding pain management, talking with the doctors. How do we do this? The whole opioid crisis has caused a problem in sickle cell disease because you have doctors, especially those who are not experts in the field, refusing to medicate people in acute crisis because, and no, you cannot. And the National Institute of Health took way too long to come out and say, no, just because there's an opioid crisis going on, people who are abusing drugs illegally, people who need it for their medical treatment, you cannot deny them that. And, again, because people don't understand their own condition, it's hard for folks to address it, and they respond very emotionally. And like you said, I can do this myself. I don't need any help. That is really a coping mechanism, and that's a reaction to the stigmatization and the disparities that they receive in healthcare from the people that they rely on, or we rely on when we can't function on our own. And I've been guilty of doing that. A doctor just asked me, well, what do you take or what do you want? But in my head, I was all ready to fight that he wasn't going to give me what I was asking for. And then I felt this little tap on my foot, and it's like, he asked you what you wanted. And then I had to apologize to the doctor. I'm sorry. It's just, it's never this easy, all of the time. And so I had to become more aware, even myself, because we too are guilty of stigma and bias, even against medical professionals. They're not all bad. And it's the ones who dedicate their entire careers to sickle cell disease is doing it because they have compassion, they have empathy, and they truly do love their work. So we also have to look at, how we're behaving even in pain with somebody who is coming and try and help us. So discrimination is not a one way.
Yeah, I'll bring in Esther. I'm just so mindful of time. Esther, so the question is, what kinds of discrimination or stigma does sickle cell patients face in their society they find themselves in different parts of the world? Esther, in Ireland, what sort of discrimination or stigmatization have you guys experienced there? You're mute, sorry.
Yeah, I have the attitude of turning my mic off. Sorry, everyone. I suppose in terms of discrimination or stigma, we would be experiencing discrimination in all aspects as people, caring for, or people living with sickle cell. We would experience discrimination in healthcare access, we would experience in education, we would experience in access to employment, we would experience in even, in the community, access to, you know, simple things like housing, social security, and all of that. And why do I say this? Stigma, in simple terms, you know, can be defined in two forms. We have what we call social stigma, which is the public stigma, negative stereotypes, and we also have self-stigma. These are stigmas internalized because of negative attitudes we experience from other people. So when you begin to experience all of this, it begins to cause access to access to services. For instance, somebody that's experiencing self-stigma because, sorry, Annette, you talked about someone that they called a Yoruba name because of her leg ulcer. Imagine you're being called, sorry, what's that again? What's the word again, Annette?
It's a long word, elego lesse.
Imagine you're being called elego lesse. That is the girl with the leg sore, something like that.
Yes.
And you internalize the meaning of that.
She did.
And how that affects how you begin to relate with your immediate community, with your other family members, and even with service. So it's not because this is Nigeria now. Don't forget, I did not leave my Nigerian culture, my Nigerian belief or religion when I moved to Ireland. I would have traveled to Ireland with those values, and it is the same values I also, you know, bring up my children with. So you can see how, you know, stigma or discrimination, I always talk about these things begin from home or even our immediate community before we begin to look at the broader institutionalized or systemic, you know, discrimination that is coming from healthcare or professionals or policymakers and all of that. There is stigma in our immediate community, within our culture, within the way we treat each other, within the way we, you know, our attitudes present to people living with sickle cell. So that same kind of stigma, Agnes, is in Ireland, within our own community here. I recall when I started attending the service, when sickle cell was growing in Ireland, we would be in the clinic. You know, the next person is coming with a child with sickle cell, and they are not talking to you. They are acting as if they are coming there for something else. Even, you know, those days I was trying to recruit people to join the society and all of that. People want to act like they don't have children with sickle cell. So where is all of that coming from, Annette?
Even the people that are actually living with the condition, they don't want to associate. And I guess I think it's the perception that we have, especially, sorry, for people from an African background, is because there's so much bad, anything to do with sickle cell, people don't want to associate with, associate with them, the people that are openly talking about it. Like, you know, I started talking about this since 2014. So people don't want to talk about it. And also, yes, I think it starts with us. It starts with us to break those barriers and just to start talking and you know, look about conditions like HIV, cancers, and all those other conditions that especially affects the, you know, white people, how they talk about it and what sort of support they are getting, I guess, because just they're raising their voices and continuing talking about this. Because I tell you, I've got people telling me here in Australia, don't talk about it. You let the government know that the sickle cell, and they'll stop people coming to Australia. I'm like, what? You know, the government, the presidents, they have advisors. They know that sickle cell is you know, a genetic condition that affects other people from certain parts of the world. Are they going to stop anyone who has, you know, like a cancer, breast cancer gene not to come to Australia? Yeah, exactly. So I think it's.
Can I also mention, Agnes? You see, there are some other factors that influence stigma. For instance, on our page one day, on our society's page one day, somebody came there to put a comment under a post that we had put out. Go back to your country with this imported disease. You see, influence coming from media depiction, you know, can also affect, you know, how we are discriminated against. They give the wrong message to the people out there. When we're raising awareness now, we try to make people understand, listen, even the, you know, the institutions and the government officials, sickle cell is not a black disease.
Exactly.
It's a disease that knows no race. You understand? It's been in the world for over 100 years now, and it's beginning to get into the Caucasian race.
Thousands of years.
So
Thousands
we
of
still
years.
have that bigger problem to fight. You understand?
For me, what I always say, like, look, okay, it's 95% people are in Africa and Asia, but we have other genetic conditions that affect certain races. And let's not just label Asians, Africans, Middle East people about sickle cell and, telling us God where you come from, and that there are other conditions that specifically affect those people in other parts of the world. And I don't think they get discriminated against like the way people with sickle cell disease
If I may,
treated.
if I may, ladies, can I just say something? If I may, the problem with sickle cell disease and the perception, doesn't matter where in the world you are, it's a branding thing. And think about it this way. I'm going to take two famous people in history, Friedrich Nietzsche and Stephen Hawking. In his day, Friedrich Nietzsche was an ill person. He was sick, his body betrayed you, and he read stories about that. But his mind was one of the sharpest of his time. And we look forward now in history, look back at this history in the present and glorify his intellect. Stephen Hawking, who came down with ALS very quickly, and in the way the disease progressed in him, from him being healthy to being in a wheelchair and communicating through a computer, he's one of the most brilliant minds. He's lauded as a brilliant mind even after his death, right? We have a lot of successful people with sickle cell disease all over the world, but we don't have branding. HIV used to be stigmatized, but then celebrities got into it, athletes, and the athletes who are living with HIV now are spokesperson. Was autism, cystic fibrosis, cerebral palsy. None of these things are really stigmatized. They were once, but now the branding, because people worked and talked about it and changed the perception. We have to do the same thing. We really need to start looking at how other people are doing things and how we can change the branding of sickle cell. That really is going to, in time, 20, 30 years from now, 50 years from now, what we're complaining about today won't really exist, because we got to do some better
And this is why I say, go on my little website where I say, let's make sickle cell famous. Let's make it famous. And if everybody will want a piece of it, and they all want to talk about it. And it's up to us to change that. And it starts with these talks. These talks can
add one more important thing, Agnes. You see, Ginger mentioned something about Mr. Hopkins' intelligence. You understand? And the celebrities. You see, sickle cell, we really don't have that caliber of people in our community coming out and speaking up for us. I've done my research. I know T-Boss has sickle cell, but how much does she stand out to speak for the sickle cell community, for instance?
Not anymore.
And again,
represents HIV/AIDS.
I know. Anyway, this is. I think we should have just put this as one topic, but we have other things, other topics that we need to go to. Just mindful. We should be finishing by now, but quickly. Well, I think we've touched about this topic about misconceptions of sickle cell. This is very important. So, what are the misconceptions? Some of them we've touched on. Discussing this, what are misconceptions that we've lived with over time? Of course, one of the most common ones is that, like Natasha said, that sickle cell is contagious. I had to tell my kids, teachers at school that no, it's not. It's not contagious. These are the things that you need to look out for. If she feels this, if she feels that, let me know. But she can play like any other child. No one is going to catch it from her. So what misconceptions have you heard over time? I'll just get anyone or two panelists to talk about this before we go to the next topic, so that we try to finish on time.
Okay, let
Dr.
me go.
Ankishet, yes, I think I'll start with you. Yeah.
One is that they die young, and they prescribe any age. Some have said 16 years, some give 21 years, some say 25 years. So what I've seen is that it's been increasing over time. And that, for me, it speaks to the fact that we have better treatment protocols and they're living longer. But that is one big thing. And so that they die young. And in this part of the world, at least I know here, before you marry, in marriage and friendships and relationships, discrimination is very, very, very common. And there's something they call in our communities here, like searching for. They go out to search in other families. If someone is going to marry in one family, they will find out if that family has sickle cell. But how do they find it? They say, is there Abiku in that family? Or depending on if you're Igbo speaking, they say, is there Obanje in that family? So it's very common for people to say, don't marry persons with sickle cell. And so for that reason, they hide their status. And let's even go beyond that. What about what's in Nigeria, for instance, there's a bill. We want to come out with a law that prevents persons who are carriers, who have sickle cell trait, from marrying. So now there's a pushback, but it's like a battle of two sides. There are those who are well learned, intelligent, educated, who are saying, no, no, no. Anybody who is a carrier must not marry anybody else who's a carrier. Who are you to prescribe who marries who? But it's something that's been discussed right now in the Nigerian Senate. So for you to, it's just for you to know out there that these are it's taken to that level. The stigma, the discrimination, and that discrimination is not just in the health sector, it's systemic. Let others speak, please.
Thank you for that. Natasha, I'll bring you in. You are from Zambia. Zambia is my home country. I love Zambia. What do you have to say about this topic, misconceptions? What have you heard over time?
Well, for me, the one that stands out the most for me is the one I spoke about in the ad video, where they say sickle cell is contagious. Because when I was in primary school, this actually happened to me. When you go to school, you share your lunchbox with everybody and you share your food and you play together. And this one time I went to school and none of my friends wanted to play with me. And one of them specifically came to me. My mom told me not to play with you anymore because you have sickle cell disease. And that has stuck with me even till now. And it's just, after learning about what sickle cell is and educating myself on it, I just find it very, I just find it really, really disturbing that people can think that sickle cell is contagious. And that's why these talks are really, really important. And another misconception, actually, I want to bring Dr. Annette into this one. Could I please ask you to explain more on malaria and sickle cell and the connection there, please? Your mic is off.
It's a mutation, the mutation of a gene. You know what a mutation is? It's just a technical term for gene changes. A gene can just change for just out of the blue. But if it's out of the blue, we say, but there's really a reason behind it. The reason it changed was because in the malaria zones, people who had a normal hemoglobin were dying off from malaria. So nature threw up a gene that was protective if it combined with the A hemoglobin that is in the carrier state, the trait state, A and S coming together is protective of the species. So to prolong the species and to ensure that the species lasted and did not disappear, sickle cell gene was thrown up. And but I don't think nature reckoned with the S gene coming together with the S gene and forming hemoglobin SS. So that's what we're dealing with sickle cell today. But the genesis of the gene was to protect the species from mortality from malaria. But that is why today, persons who have hemoglobin AS, the carrier state, like myself, we do not have a high risk of severe complications. Not that you don't get malaria, you don't get severe complications of malaria. So that, for instance, cerebral malaria has never been found in anyone who has a sickle cell trait. So it's protective of malaria, but persons with sickle cell can have the malaria and it can be devastating. And those who are AA, who have a normal hemoglobin, can also have severe complications of sickle cell, of malaria. So that's the relationship. But the map I also showed is that one that shows that the sickle cell map superimposes directly on the malaria map. Wherever you have malaria in the world, there you have sickle cell as well.
Thank you. Thank you.
Sorry, I was mute. Aliu, do you want to come in and just, what misconceptions have you encountered in Gambia?
Thank you, Agnes. Here in the Gambia, like I said, we have a different perception, and then the stigma is if you are a sickle cell patient, they see you as dead and work. Like they give you a death sentence. Like Dr. Annette said, they give it an age limit. Sometimes they will say when you're 6, you will die. After when you pass 6, they will say, okay, when you're 12, you will die. And from there, they will give numbers. They will keep adding the numbers, you know. And the biggest stigma is when they say that you are a sickle cell patient, they only see you as a dead man walking. Even your family members disregard you as somebody who is important. You know, they don't give you that that right that you have as a human being. They don't treat you. They only see you as like a liability to society and also a liability to the family. So even for them to take care of you, it's a problem because they will say, okay, it's not necessary to invest so much. We will be wasting our money because maybe in the next 2 years you'll be gone, you'll be no more. So that is one of the discriminations that we have here, and then it's really hard. But I thank this initiative because I know from here, people will start seeing us as people that are normal and people who can live long. And thanks to Dr. Annette for that, that brief clearance on sickle cell and malaria. Because here also people will tell you if you have sickle cell, then you won't have malaria, which I think is totally wrong. I'm a sickle cell patient with SS, and I also used to suffer from a very, very severe malaria, which knocked me down. Yeah. So definitely, this program will definitely enlighten more people, and then it will change the misconceptions. Thank you.
Thank you.
May I just add, Agnes, one last thing, Agnes, just to point out that in families, it's not every family that's supportive. We've had to counsel families where children, siblings are very antagonistic against their own sister or brother who has sickle cell because they feel that their parents are paying too much attention to that one child. Because we had to bring in a family not long ago where one child tried to stifle her sister with a pillow. The reason being that she said, the simple thing she said to us was her mother allowed her sister to bathe with warm water in the mornings, whereas she would bathe with cold water. And sometimes they would ask her to get the warm water for her sister. And she wasn't able to just get her mind wrapped around that. And she brought a pillow at night. Her mother caught her, pressing her sister's face with a pillow on the bed. This is a real life situation, real life scenario. We have to counsel the entire family, and they're still in counseling. And it's happening in other families. It's not just, so it's not all families that are supportive. We want to counsel families together and ensure that they're supportive of their child or the member of the family who has sickle cell, and explain to the others that they don't have it and it should be part of the management team or the caregiving team for their sister or their brother. Just want us to know that that happens.
Yeah, well, thank you. Thank you so much. I think for me, I only have a few bits. I think this goes to families, especially. I've heard of marriages breaking because they feel sickle cell is a woman's fault. If somebody has a child with sickle cell, they're going to, especially the man's family, they're going to blame the woman. They brought this disease in the family. Sickle cell is a genetic condition, people. It comes from both spouses. So if you have a child with sickle cell, make sure that you just get tested to know what sort of traits you have, and then you can follow up with other kids and make that informed decision. The other thing that I've seen also in my country, in Zambia, they always say sickle cell affects people that come from the northern part. I think I've got Sister Sylvia here. I think I'll bring her at the end just to speak about that. They say it only affects people that come from the north. I don't know how that came about. I have nothing to read to sort of know why they brought that up. Maybe it's got something to do with malaria. I don't know. Again, sickle cell is a genetic condition. It does not skip a generation. That's another myth that I've found. It doesn't skip a generation. It's a probability. If you've got somebody with a trait AS and AS, there's 25% of a chance of having a child with sickle cell anemia. For us, my husband and I, we have 4 kids. We were lucky. We had the first 3 without knowing. And then our 4th child, that probability came and she got the SS. Later on, we found out that out of our kids, one of them is a carrier and one of them are okay. They don't have the trait. So it does not skip a generation. It doesn't affect one spouse. Both spouses have to carry the gene. In Zambia, if you're watching people from Zambia, it does not affect only people from the northern province. It is a genetic condition. So unless anybody has anything on the panel to say about this topic before we go into our last topic, we get questions and then hopefully we can leave as soon as possible because we are way out of time.
Okay, the other thing to emphasize in the inheritance pattern is that it's in every pregnancy that chance thing operates. It's not because sometimes here in Nigeria we hear parents say, "Oh, I have one child that's already sickle cell, so the others are going to be normal." And I will say, no, please, it's in every pregnancy we're talking about. If both of you are carriers, then in every pregnancy it's like lucky dip, and your mother picks up one paper and opens it and it's sickle cell. You can have a family. We have, when growing in my medical school, when I was training, 7 children in the family, all were SS. All 7 children sickle cell. And the converse is also true. 4 children, all AA, not even a carrier, for 1 to parents who are both carriers. So it's in every pregnancy that that chance operates. It's not out of 4 children, 1 will be SS. In every pregnancy, so we need to educate properly.
To emphasize that, yes, every pregnancy, 25% depending on whether you are AS, sometimes 50% if you are SS and married to somebody who's AA, and other probabilities. So it's every pregnancy. Well, thank you so much for this. This will bring us to the last.
Agnes, can I just differ a bit from a more what we like call modern experience in terms of misconception there. This is from my own personal experience. I suppose people with sickle cell, their intelligence go unrecognized. That's my own view. And because their intelligence go unrecognized, this affects the guidance they have around which career pathway they take. For instance, and we know the relationship between your career and access to employment and poverty. You understand? For instance, I'll tell you, when my daughter, the second one with sickle cell, was thinking about going for medicine, she wasn't encouraged at all. Oh, it's going to be too hectic a degree. It's going to be this, even the long hours waiting, blah, 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 blah. If she did not have a mother like me, she would have crushed her dreams. But she was very intelligent to study medicine. But because of sickle cell crisis, hospitalization, you understand, the guidance and advice coming from health professional was not, something that will build her economically in future. And we, as a group, in Ireland, we begin to counsel and mentor a lot of our young people that are intelligent around their career pathways. And one of my, colleagues here in Ireland, her own daughter is doing physiotherapy. And somebody else, her daughter graduated as a pharmacist. You see, we're beginning to have, children or young people with sickle cell, picking up career pathways that people never expected them to achieve in life because of their condition, because of sickle cell. So for me, that's a misconception that is out there. And for all the, carriers or warriors or sickle cell families listening to this, you have to encourage your children. You have to support them. You have to give them no matter what support you can, because it is for their own benefit. You don't want them ending up on social benefit, social security, or disability allowance, living a life of poverty. Their career matters a lot to their access to employment in life. Thank you.
Thank you so much. This brings us to the last subtopic. So we are saying, after all this, just a tiny bit of what we are, I think we needed 3 hours. How can we break the silence? How can we break the sickle cell? So that's the last subtopic. Then we'll get questions before we close. I'll bring in Dr. Ankishetty. how can we break the silence? That's one of the subtopics, and we put that deliberately because we want to encourage this. We want to encourage, one of the things we feel as Australian Sickle Cell Advocacy is continuing to talk about it over and over and over again, and that's why we're having the talks all the time. But what other areas, what other aspects can we do to make sure that we are breaking the silence, and in turn we are going to break the sickle?
Thank you. I think very simply put, we live in a time, we're just fortunate we live in this time where we have access to information everywhere and social media. So we should take advantage of the moment we're in, seize the moment and make it work for us. And I think what we're doing now with this series, 10 series plus 2, is part of the process, maybe even kicking it off. But wherever you find yourself, in whatever space you find yourself, in your family, in your community, in your workplace, you speak about sickle cell. I must say that over the years, we've come a long way. I speak from my own workspace, from when we carried out a national survey in Nigeria in the 1980s about sickle cell. When we went to the communities, people would hide their children, would not come out to say their children had sickle cell. It would be the neighbors that would tell you, next door, there's a child with a biku, but in that household, they would not tell you so. But now, when we go out to the communities, I think that silence has been broken. There's a little bit of, there's more name recognition. Even in English, they understand that the name is sickle cell. And they bring out their children, doctor, my child has sickle cell. So we're beginning to see more of that. It's not empirical, but it's clear that even here where we work, in the same workspace, in the same environment, where 30 years ago, they would hide their children and not talk about sickle cell, and you'll only hear from neighbors. Now they come up to say to you, my child has sickle cell. But we have a long way to go. We in the social and the civil society groups have to hold government to hold them accountable, hold their feet to the fire. I speak from the Nigerian point of view. I know that sickle cell in Nigeria is just there in the government space, just on paper. There's no funding, there's no government commitment, there's no political will. But if you go out there globally, there's World Sickle Cell Day, there's the United Nations has recognized sickle cell, WHO has recognized sickle cell. So there's already the discussion, the conversation going on across the globe. But we must hold our governments accountable, that they have signed conventions and treaties in the area of sickle cell. So then what are they doing to implement those treaties and conventions? So I think that it's for civil society to hold governments accountable. I know that it's in the Western world, they're doing a lot more than we are doing here in Africa. So I speak to my African people, to our governments, if they're listening, and if they're not listening, to the CSOs that are here present, hold your governments accountable, hold their feet to the fire, speak out, and let persons who have the condition, like we have persons living with HIV and AIDS, let's have persons living with sickle cell disorder speaking out as a strong advocacy group to government to advocate for sickle cell.
Yes, well said. Thank you. So if anybody has any question, please raise your hand. I've got Aliu. Aliu, do you have something to say? And all other participants now, you can come in if you've got a question. Just turn your camera on and you can ask a question. We are almost wrapping up. I'll be checking Facebook too for the questions if there's any questions. Aliu, you have your hand raised. Do you have a question? Do you have anything to say?
Angie.
Yes, go ahead.
Okay, I would like to say that in my time that we live with sickle cell, like people, I am a warrior and I'm very proud. Talk about sickle cell everywhere I go, like people to me, and sometimes people even tell me that I'm not a sickle cell patient because of the I do and how happy I am to say that I'm a sickle cell warrior. You know, I think it's for us to start celebrating our sickle cell warriors, and we talk about it. The more we talk about it, then the less the misconceptions, the less the discrimination, and the less the stigma. So what I wanted to add.
Oh, you finished? Sorry, I couldn't hear that. Natasha, what do you have about how can we break the silence? How can we break the sickle?
Well, That is a very good question. I think all of us here are rooting behind having one voice. And the one thing that I've noticed is that in our community, especially in Zambia, where it seems like instead of standing together and fighting this cause, we are standing against each other and competing against each other, which shouldn't be the case. We should all speak one voice. We should all work together. If we want this to make Sickle Cell famous, we have to work together and we have to speak the same language. That's the only way we're going to get this out there and make people aware of what's happening. We have like things like cancer, they have walks, they have rides, bicycle rides, ride for cancer. We can also do things like this, a concert for sickle cell anemia and different things. We just all have to be on the same page and speak the same voice.
I think that's very true, Natasha. Like, you know, what I've seen, some of the bits and parts I can relate to. Also in Australia, Dr. Anki Shetty, World Sickle Cell Day is not recognized as well. So we follow the American calendar. That's something that we are going to do. As an organization, we've taken that up to speak to the policymakers, and hopefully one day that will be done. But at this point, you know, people might think we have it easy also here. It's not. They're working together as well. We've been trying to work with other similar organizations. We find it tough as well. And but yeah, I think speaking one voice, and if people are really serious, and this is why the other day I was saying, you know, be an advocate for a good reason. You should have be an advocate at heart and do it even without the money or with the money. But you have to have that. The number one thing has to come from the heart. So do it with a good reason. Be able to partner with other organizations. Be able to speak out. Be able to support one another, and do not fight against ourselves. We are fighting one cause. We have an enemy, and the enemy is sickle cell. So let's not fight against each other. I feel we can do better as humans to actually raise our voices in a good way. And, you know, don't get worried if people come together like this, people getting worried like you're forming an international organization. We are not. All we are doing is talking about sickle cell so that we can break the silence, we can break the sickle, and we can bring other people also on board. You know, join us. Are you living with sickle cell disease in Australia or in another country? Join us. Let's have, I've seen somebody say the viral voice, hashtag viral voice.
One viral voice.
One viral voice. Hashtag, one viral voice.
I love that.
Yeah, so united we stand. We had so many hashtags. Together we rise. No, break the sickle, break the silence, everything. So yeah, I think we are almost coming to the end of our session. I'll just check Facebook, but if anybody wants to turn their camera, I think everybody now, you can turn your camera on. Let's see who's on. Let's get a big picture we can share with the world. Yes. We are breaking the silence. We are breaking the sickle. I want to see we are 22 participants plus the panelists. Please turn on your cameras. Let's see who's here, and let's celebrate people living with sickle cell. We are not going to feel sorry for you guys. We feel your pain, but you are not going to feel sorry because, as I said, everyone is carrying something. You don't know what people go through. And maybe sickle cell is even much better than what other people go through. So let's not feel sorry for anyone, but we are in your shoes to know that, you know, it's a hard condition to go through, but we walk the journey together. And so thank you for everybody who's come on. We are 22 people on board. And if anybody has to say, I want to bring in quickly Sister Sylvia. Why do they always just say that only people from northern province in Zambia get sickle cell? I don't get it. Mwewa Juyu, Mwewa Zambian. I don't get it.
Yeah, I think, thank you very much. This is such a great opportunity for us to share what we need to share so that we can go viral in a good way. So I think, you know, it's a myth, but I think from the northern part, the Bemba speaking, I think it's because they wanted to keep wealth in one family. So there were intermarriages in the families. They would marry in the same family, the cousinship. And so it meant that if there's the sickle cell in the family, so many other people would get it. So in short, it's a myth, because that was a long time ago when children used to really get so sick because of the sickle cell disease. But it's no longer there because now there's so much intermarriages in the, you know, in their own environment. So it's just the.
But has a survey been carried out? A national survey? Have you had a national survey to determine how much of sickle cell you have and where, and the distribution across?
I think probably this is what is going to happen, Doctor. This is one of the action points that we can take, so that you know, some of these myths can just be crossed off, because we cannot live with myths. We need to be helping and finding out the real issues, why they cannot probably give sickle cell patients or sickle cell warriors an independent word, so that when they're even doing the research or how medicines are working, they'll be able to, you know, to know what's going on. So this is why, for me, as a caregiver, I am so excited about this whole thing, that we've come together to see how we can make a difference in making the warriors' lives better.
Yeah, and bringing all the other organizations in Zambia, as we said, Natasha said, let's work together. We are all fighting one cause. Let's come together. Anybody has anything to say before we wrap up? We get a nice picture.
Zambia.
Yes, if I may, I would just like to expand on what Annette said earlier about holding governments responsible. World Sickle Cell came about because a national from Congo Brazzaville who lives in France approached her first lady and got the first lady to talk to her husband about sponsoring a bill for sickle cell. It passed in 2008. I found out about it in 2009, started calling all of these different embassies to find out what was going on. And in 2010, we held the first World Sickle Cell Day event at the UN with the festival at Dag Hammarskjöld Plaza a few blocks away. And in that resolution, there were 7 items in there that they said, you know, creating satellites, creating comprehensive care, sharing information, collecting data, all of these things that they said, wonderful, except they did nothing starting the next year. 2 years consecutively after that, I had the First Ladies Roundtable on sickle cell, and then the third year, First Ladies Roundtable on sickle cell and malaria. One of them, the First Ladies just decided not to show up, okay, because we hold our government accountable, and we do advocate. We're in Albany, we're in Washington, D.C., we're in our municipal governments advocating for sickle cell disease. That needs to happen in every other country where this disease exists. And that we have a tool. It's called the Resolution for Sickle Cell Disease, A263. I'll share that, you know, with everyone. We'll put it on Facebook. But we need to hold the presidents of the countries responsible, because 26 countries, including Nigeria, were co-signers. And some European countries as well were co-signers on this bill, and it passed, and nothing. The governments are supposed to allocate 15% of their I think it's GDP or GM, I think it's GDP, to these programs for sickle cell disease, and they've done nothing, and that's because no one has held them accountable. Now they're all going to be coming here in a few weeks to New York for the general sessions, for 2 weeks at the general session at the UN, and we need to start showing up at the UN and start approaching them there at the United Nations through the Eco-Social Council and saying, keep your word. Even with the Millennial Development Agenda, sickle cell falls within that, and we need to start making them keep their word.
Well, thank you so much. This has been very, very insightful. It's been fire, very informative, educational, everything. So these sessions will continue on Facebook, and this recording is there for people who have questions. Please send them through. I've seen a few comments on Facebook here. Annie Chantel is one of us who couldn't join us for whatever reason. Zoom couldn't allow her. She said in Cameroon, people say women with sickle cell can't have kids. That's just some of them. Very good discussion from Lola, and loving this presentation. Too much sympathy. Yeah, so some questions and some feedback on Facebook. But this recording is I will continue being on Facebook. If you've got any questions, email us to info@sicklecelltalks.com, or just post your questions on Facebook. And next week, we are back on Saturday. We have another team who are going to present another topic. We'll start advertising on Monday. And so how people are affected, you know, we just want to like that they want to be acknowledged as living with a condition and not being able to be to feel sorry for them or being not feel pity for them, but we do understand what they are going through. We should walk in their shoes. So let's try to understand what they are going through. They do not want us to feel sorry again. So better treatment options for all, especially in developing countries. That's something that we've heard from Dr. Anki Shetty. Let's hold our countries accountable, especially in African countries and other developing countries. Let us use our voices for the right reasons and do not abuse the disease for personal gains. For people living with the condition, understand your condition, know your body, know your triggers, understand the symptoms, side effects, take control of your body, be on top of your hospital appointments, always consult your GP, and that's something that I should have emphasized from the beginning. Consult your GP, go for the second, third, fourth, or whatever, or opinions. And I'm talking this from an experience as a mom. That's what I used to do for my daughter. As for caregivers, let us unite to amplify our sickle cell voices. It starts with us and it starts now. We can change the world. There's power in numbers. For us in developing countries, let us talk to our governments, as Dr. Anki Shetty has said, to take sickle cell as a priority. So let's ensure that we recognize that it's just like any other disease. It may not be easy, but we'll get there. We'll get there. So I think that's my summary. I'll just give the panelists to say one or two things before we leave, if we don't have any questions, and we can wrap up. I'll start with Aliu, your last word, 1 minute, please.
Okay, thank you, Anya. I think what I want is unity, strength. So we are all fighting illness. Let's come here and fight as one.
Okay, yeah. Thank you. Esther, your last words, please.
Are you getting?
Okay. I suppose we should all continue to speak in one voice. We should learn to reposition and rebrand ourselves, and we should not allow our warriors' intelligence to go unrecognized. So keep going. We'll definitely get there someday. Thank you, everyone.
Yeah. Thank you. Natasha, your last words before we finish.
I'd just like to say, Team Aska, thank you for this opportunity. And this has been very amazing. I learned so much from Dr. Annette. I mean, I'm a warrior, but the other things that I've learned today, and it's really amazing to know certain things. And let's keep talking as one voice and together as one.
Okay. Thank you. Ginger, before we give Dr. Anki Shetty the last word.
Yes, ma'am. This was a pleasure to be here. I'm actually started a watch party on Facebook and have been in the chat on both Zoom and Facebook, making comments, and I'm making a comment in the watch party saying that this has been a great session and inviting people to join us next week. I think this is very important, and the panelists will change and the perspectives and the comments from everybody will change. However, we'll see so much commonality, and hopefully that we can build from that. We're not talking about an international organization. We're talking about international conversation, and through that change, affecting positive change.
Definitely. Dr. Anki Shetty, your last word before we wrap up, and thank you so much for being part of this.
Thank you. I want to thank you, Agnes, for the vision, for the foresight, and thank everyone in the group. Like I said before, an eclectic, diverse, very fantastic vitality everywhere. So I just want to say this is something we need at the moment. Let's seize the moment. This is the era of technology. Let's use it to push our agenda out there. And remember, anything you say or do, remember to put out too that sickle cell is not a death sentence.
Yes, please. Can people put their cameras if you are comfortable? Let's get a group photo before we go. If there's no any other questions, please put your pictures. I want to see your beautiful faces. Please, let's put our pictures. Yeah. Who do we have? Ari, Jaime, please. Toyin, you were
turn on my camera, please.
Okay,
turn on your cameras, please. Esther, are you doing the pictures? Esther is a camera lady. I'll take some as well. Let's smile for the photos. I'll start with the first page because we've got two. I don't know why we couldn't
Got
have
2 pages.
Okay, are we smiling?
Yes.
Yes, we are smiling.
I'll go to the next page. Well, I think that's it. Anybody wants to say something before we go? Thank you so much, Facebook family. We love you, and let's continue talking this voice. We are back next week with another session. We are done session 1. How good was that? Esther, how good was that?
Fantastic.
Great one, everyone. Great topic,
Yeah, great
everyone.
job.
Well done, Agnes.
Thank you, Sakina. Thank you so much for joining us, everyone. We are back again next week. It's up to the session 2, what time will work for them. For us, me and Ginger on polar opposites, it's 11, almost quarter past 11 p.m. for me. So it's up to session 2 next week. So we'll tell you the time on Monday or tonight when they decide. They'll let you know when they're coming on next week. So we are done. Whew, we finished. So up to the session next week. Thank you so
done.
Good job, Agnes.
Thank you. Thanks, everyone.
The
Thanks for
hostess with the
joining us.
mostest.
Yeah. So session 2, if you want any notes, just let us know.
Right.
Okay.
Bye.
All right. Bye, everyone. Have a nice day. Thanks.
Bye, everybody.
Bye, Facebook family. Bye-bye.